Yeah. So risk assessment and CHIP score. So the background has been said by Dr. Varma, so that saves me a lot of work. The concept of complex high-risk indicated percutaneous coronary intervention has attracted much attention in the recent times. It's important to assess the potential risk of a PCI objectively, considering both the impact of the patient and procedural factors on outcomes by developing a CHIP score. So this was addressed by a large study, observational study from the UK, the British Cardiovascular Interventional Society database from 2006 Jan to 2016 December, in a period of 11 years, where they studied the data of 313,000 patients. So a multiple logistic regression model was developed to identify variables associated with in-hospital major adverse cardiac or cerebrovascular events, MACs, and to construct a CHIP score. So the cumulative effect of this score on patient outcomes was examined by them. So these are the multivariate adjusted baseline and procedural covariates associated with the in-hospital MACs. So if you see the odds ratio, down here, the one which caused maximum MACs was the upfront LV support. The need for upfront LV support indicated the highest risk, and odds ratio of 8.02, followed by LV dysfunction, EF less than 30%, 1.95. Then renal disease, 3-vessel, multi-vessel PCI, triple-vessel disease, and age more than 80, and peripheral vascular disease, then lesion length more than 60, and female. These are the major factors which influenced outcomes. And the procedural factors, then rotational atherectomy, left main PCI, and the need for dual access in some CTOs. But they didn't find any significance for CTOs per se, probably because there are a lot of CTOs which are fairly simple. But those who needed dual access probably had a higher risk. And variables independently associated with increased in-hospital MACs were total 7 patient factors: age more than 80, female sex, previous stroke, previous MI, peripheral vascular disease, EF less than 30%, and chronic renal disease. And so they were defined as CHIP factors, patient factors. And there are 6 procedural factors they identified: rotational atherectomy, left main PCI, 3-vessel PCI, dual arterial access, planned LV mechanical support, and lesion length more than 60 millimeters. So these are also CHIP factors, procedural CHIP factors. And based on the observed odds ratio, the planned LV mechanical support was given 3 points. Then age more than 80, peripheral vascular disease, EF less than 30%, and CKD had 2 points each, and remaining factors 1 point each. So this is the distribution of CHIP factors in the total population. So about 35% of the entire the PCIs were having 0 CHIP factor. Then followed by CHIP 1 with 31%, like that. And those with CHIP factor 5 and above were much less. And what happened over the years? Is there a change in pattern from 2006 to 2016? So there was a significant increase in procedural complexity. And what are the effects of each CHIP factor? So if you look down, if there is no CHIP factor, the in-hospital max was 0.6%, in-hospital mortality 0.1%, major bleeding 0.3%, acute procedural complication 3.1%. Whereas if you come down, it is an increasing risk for each of these procedures. Like previous MI, if it is the max increased to 1.2, female 1.3, total length of more than 60 millimeters 1.5, and the ejection fraction less than 30 is 3, and planned LV support 15.2. So all these factors increased with all these CHIP factors in a grading fashion, with the highest risk being planned LV support. Probably that identifies a group which is high risk in the beginning itself. And these are the trends, temporal trends of all these over the years from 2006 to 2016. The chip score per case was 1.06 in 2006. That increased to 1.49 plus minus 1.58, which is understandable because there are a lot of advancements in hardware and other technology, and much more and more complex cases are being done. The same applies to all these. And the in-hospital major adverse cardiac or cerebrovascular events. So this, as I said earlier, the number was a staggering number, 313,054, though it is a registry. And if you look here, so there is a mistake in this chart in the article itself. So the yellow one is in fact cumulative max, and the red one is max per score. So the risk of those with zero chip factor was, say, 0.6%, which increased as the number of the scores increased. For example, a chip score of 5, that the max per score was 3.2%, whereas the cumulative max means 5 plus 5 and those above 5, about 4.4%. So, and as the scores increase, there's an exponential increase in the risk. And here the risk factors are given. This is a score, patient factors, and procedural factors. And in hospital mortality and major bleeding, procedural complications, again, depending upon the number of chip factors, there is a grading and an exponential increase in all these complications: mortality per score, the major bleeding per score, and procedural complications per score. All these expectedly increased and exponentially as the score increased beyond, say, 5. So these are the results in the total of 313,000 patients included. 7 patient factors, 6 procedural factors were there, and the mean chip score increased from 1.06 to 1.49 over the years. A chip score of 5 or more was present in 2.5% procedures in 2006 to 5.3% in 2016. Overall in hospital, max was 0.6% with chip score of 0, 1.2 with any chip factor. And as the chip score increased, an exponential increase was observed. The cumulative max for procedures associated with chip score of 4 plus or above was 3.2%, 5 plus above was 4.4%. And all other adverse clinical outcomes were more likely as chip score increased. Then there is some study limitations. This was an observational study. Then high-risk cases, acute MI, and cardiogenic shock were excluded. These are probably the highest risk cases. They were excluded. So these won't be applicable to such situations. An effect of IVL or orbital atherectomy use was not studied, probably because the study was only up to 2016. And I think newer ones will probably include this also. And this data set did not include anatomical factors such as tortuosity bifurcation, then patient factors such as hemoglobin, pulmonary function, that might also have independent impact on outcomes, were also not considered. So the summary of this study was 7 patient factors and 6 procedural factors were independently associated with adverse events. As chip score increased, exponential increase in max and other adverse clinical outcomes. Identification of chip factors and scores may facilitate personalized assessment and management of complex and high-risk patients undergoing PCI. Then there's another study, interesting study, a novel risk score to predict 1-year mortality. So the initial one was addressing only in-hospital mortality. So this studied the 1-year mortality in patients undergoing complex high-risk indicated procedure, percutaneous coronary intervention. So the objective was to identify complex high-risk indicated percutaneous coronary interventions and compare their outcomes with non-chip patients. A chip score was created to risk stratify these patients. Their chip score was different from the previous one. And the methods, the chip PCI was defined as any of the following: age more than 80 years, EF less than 30%, and dialysis, prior bypass surgery, treatment of left main, chronic total occlusions, more than 2 lesions in more than 1 coronary artery. The primary endpoint was 1-year all-cause mortality. The logistic regression identified independent predictors of 1-year mortality, and the odds ratios for those predictors were used to create a CHIP score. Then they classified patients into low-risk, intermediate, and high-risk groups. So in the results, their numbers were less than the first one, but still quite good, 4,478 patients. And of these, 38% were CHIP patients. And there were total deaths, 85 deaths, that is 2.2% at 1 year. 4.1% in the CHIP patients versus 1% in the non-CHIP patients. So it is very statistically very significant. And CHIP PCI was an independent predictor of mortality, odds ratio of 2.59. And 4 CHIP criteria were independent predictors of mortality according to the study. Age more than 80 years, they gave 3 points. Dialysis, 6 points. EF less than 30%, 2 points. And number of lesions treated, more than 2 points. So about 2,752 patients were categorized as low risk with a score of 0, 889 intermediate risk with a score of 2 to 3, and 269 high risk patients from score of 4 to 13. The 1-year mortality rates among these 3 groups were 1.24%, 2.4%, and staggering 10.86% respectively. The summary of this study was in patients with CAD undergoing PCI in the absence of STEMI or cardiogenic shock. They also excluded STEMI and cardiogenic shock. The 1-year mortality is about 2%. CHIP PCI defined by the presence of age more than 80 years, LVF less than 30% before PCI, dialysis, prior CABG, treatment of left main or CTO, or more than 2 lesions in at least 2 coronary arteries is associated with a 2.5-fold higher risk of death. CHIP score discriminates risk, and patients with intermediate and high risk scores have a 2-fold and 9-fold 1-year mortality rate, respectively, than those with a score of 0. So let me conclude. The knowledge of CHIP factors increasing max risk help assess in-hospital and long-term mortality. The identification of CHIP factors and scores may facilitate personalized assessment and management of complex and high-risk patients undergoing PCI. CHIP scores, of course, will get more refined with further studies in future. Thank you.
Thank you, Dr. Rajiv. Actually, you realize that this is an evolving field, scoring, and when we say CHIP, we should all mean the same thing.
Yeah, yeah.
My thought was at some stage it might come C2H3I4 CHIP. So if you can, something like chat's first score. Maybe the deliberations here later will lead on to some scores, and we can have a CHIP group which can evolve a score on our own. We have eminent people in this faculty itself who can think together and develop a CHIP score, or a C2H3I4 means higher the indication risk and everything can come in one. Maybe that's a thought. Yeah, in fact, the CSI can take it up in a national level. They can also build up in bigger numbers. Very true. Our CHIP numbers are really good.
Rather than terming as CHIP CTU, it should be in your first data, which was retrospective data, they have not included CTU. Yeah, they have included CTO, but they didn't find a difference. Yeah. They explained that probably the so-called CTOs were fairly simple ones, or the other ones were not fully intended to go full throttle. Right. Maybe when the risk was there, then probably they stopped it. So in the but when you used dual axis, then the risk was more. Yes. That's the way they have put it as dual axis is a high risk from the point of view of procedural aspect. Yes. From the patient characteristics, somehow CTO has not been highlighted. Yeah. In the second study, but that makes sense. The CTO part. Second study, is it a prospective study? Yeah. Prospective. The other was a retrospective. Yeah. So I think we are making some attempts to define this again. And these are all, the first study is a long back study. Yeah. So I think in the years to come, we will be very clear about what is really a CHIP case. Yeah. Whether whatever the terminology is given. We have to give the patient the risk aspect of the procedure, the benefit aspect. That's the most important thing. Yeah. I think the situation is evolving. I'm sure this sort of conferences will certainly add to value of a particular point. So,
your comment?
Just one point, sir. Actually, any patient who comes to the table for an intervention is at risk of having an adverse event, and we are planning for success. This is a continuum from 0 to 100. I think it's very difficult to cut off and say so and so is a chip patient, so we do something special for him, so and so is not. I also have a problem with excluding patients with ACS who constitute about 40% of the patients whom we are going to perform procedures for in all settings across the world. You can't say, no, he's an ACS or he's a MI, so he's not chip. I mean, the poor man is at risk of dying and he requires, or lady, sorry, I want to be gender specific here. So, I mean, I think they need just as much assessment, just as much care. The important thing for us is to plan what we need to do in a given situation and have all the material that we need for that particular situation. I think definitions are, the disease hasn't read the book, so we need to evolve a little more.
Yeah, but
one comment from one more from the
just one.
No, the thing is, if you're having a chip and you have an option of doing electively, planning and doing a chip procedure will have much better outcomes than trying it ad hoc. That is the message that should go.
What they said is ACS, anyway, you know that it is a high risk and you don't have time to do all this planning.
Go ahead.
Dr. Rajiv, basically, even correlations between syntax store and chip store. How to?
No, there is no, because that is mostly angiographic procedural this thing. So here it's more important because it's an outcome related thing, not just
looking at the image alone.
The
patient as a whole.
Syntax score is just to see whether somebody will do better with surgery or PCI. It's more of anatomical.
Thank you, Dr. Rajiv. We'll conclude this session.
Thank you.